of these 2 days. I'm sure that everybody now is a little bit tired. I'm gonna try to make it very simple and very fast as much as I can. We know that ICP, or increased intracranial pressure, is very devastating condition in critically ill patients. It can result in catastrophic brainstem herniation and ischemia. We need to monitor ICP to predict the cases of high ICP. The gold standard of ICP is remaining. You hear me, Walid?
I can hear you well. It's just full screen. Yeah.
Okay. So the gold standard of monitoring and measuring the ICP will remain the invasive one, that we introduce a catheter and we measure the ICP, standardized to be more than 20 millimeter of mercury as an intracranial hypertension. What some people, or majority of people, they are relying on in ICU, especially in trauma cases, that they monitor them without invasive technology, relying on clinical manifestations. The decreased level of consciousness, seizures, and many other things. But this is not typical to happen in critically ill patients who are intubated, fully sedated, sometimes must relax it. And if you rely on fundus that the people arguing still to use it in critically ill patients, examining the fundus for papilledema. Papilledema takes several hours to appear, while the dilation of the optic nerve sheath can happen after increase of the intracranial pressure within several seconds or minutes. Identifying high ICP in many or majority of unconscious patients might be indicated, but it's strongly indicated in TBI, traumatic brain injury, especially if you have a Glasgow score less than 9 and you have a normal CT and age is above 40, abnormal posturing, or hemodynamic instability, then the ICP monitoring is considered in most of the guidelines very highly indicated. Then you go with invasive again. You have a lot of complications happens with invasive ICP monitoring, like bleeding, infection, malfunction, and not only that, but also to have a neurosurgeon committed to do this for you. And you convince him or her to insert an invasive catheter into the brain of a traumatized one to get ICP monitoring because you are worried about the ICP. It's very difficult sometimes. Difficult to convince neurosurgeon, difficult because of thrombocytopenia, coagulopathy, and instability. So you have to have a technique or a way or a modality to diagnose the intracranial hypertension non-invasively. CT brain, MRI was found to be useful. And there is literature with reviews to show that using CT to measure the optic nerve sheath, to measure the size of the optic nerve sheath diameter, to predict, among other signs on CT, to know if there is increased intracranial tension or not. This evidence is supported in the literature that the CT can predict high ICP when they measure the intracranial pressure, the optic nerve sheath diameter. Very good sensitivity. So you can rely on to rule out increased intracranial hypertension. Specificity is very low. Optic nerve sheath diameter measured by CT was a strong predictor of increased ICP compared to other CT signs. There is no doubt. The evidence also showing that people with traumatic brain injury and increased optic nerve sheath diameter in their CT, which the radiologist can read it for you, and you can learn how to measure the optic nerve sheath diameter in CT, The higher the optic nerve sheath diameter on CT, the worse is the outcome. But again, you need to move your patient out to CT room or MRI room. Unstable patients, availability is limited sometimes in the middle of the night. You need time to do, and it's expensive and radiation exposure. What about the ultrasound, which it can be bedside, portable, non-invasive, cheap, quick to do, easy to repeat, and easy to do it also. The rationale behind measuring the optic nerve sheath diameter relies on anatomical facts that the optic nerve, which is the end of the globe and the end of the retina, the araconite, the layers surrounding the optic nerve, is in continuity with the layer surrounding the brain. So the optic nerve in your eye goes backward. The sheath around this nerve, which is particularly the subarachnoid area of the optic nerve sheath, is in continuity with the brain covering or the subarachnoid space of the brain. So by logic, and this is evidenced, anything that increases the pressure inside the brain will reflect downward to increase the pressure around the optic nerve and distend the sheath coverage of the optic nerve. The technique is very easy and settled in the literature. You have to go with high frequency probe. You have to see the globe as you see it here. This is the eye globe, the anterior chamber. This is, sorry, the vitreous, the posterior chamber. And you should not see the lens here because the lens is hyperechoic and it might cause a posterior to it shadow that does not reflect well the optic nerve. If you look carefully behind the vitreous, you're gonna see a layer, which is the retina, surrounding all over. And then at the middle of the retina, you see the macula. Indentation in the retina is called the macula. Behind to this, you're gonna see hypoechoic shadow. This black area, which is longitudinal, is the optic nerve. The sheath is the layer covering the optic nerve. When the black turns to be white on this side, when the black turns to be white on the other side. So the sheath are the hyperechoic white layer covering this longitudinal tube, which is the optic nerve. What you have to do is you have to use a low penetrating probe, superficial structuring probe, high frequency probe. Typically we use this. And we set the patient in 45-degree up or 30-degree up, use plenty of gel. Don't press on the globe. And better to avoid any eye with evidence of trauma because you might cause injury. Otherwise, there is no reported side effect of using the probe even repeatedly on the eye. There is no thermal injury, no any other reported injuries. You should not press, but you have to be very gentle. Use plenty of gel. You can see the optic nerve very clearly, and then you freeze. You should avoid, as I mentioned, the lens, which you see here. This is the iris. This is the anterior chamber. This is the posterior chamber. Once you see the lens here, you rotate your probe to be more directing nasally. Then you're gonna see the optic nerve as you see it very clearly here. You have to be sure that the borders, the clear border of the optic nerve is clear. So the width of this optic nerve from the hyperechoic border here to the hyperechoic border here is the optic nerve sheath diameter. Where to measure it? We measure it posterior to the retina, perpendicular to the nerve in around 0.3 to 0.4 centimeter from the back of the retina. At this area, 0.3 to 0.4 centimeter, this is the widest part of the optic nerve. You measure the diameter here, And this will be a number that you use it when you do the examination at least 3 times, preferably bilaterally, and you take the average of this number. So 0.6, 0.5, 0.5, 0.4, you take the average and you rely on. There is a variability in the cutoff point for the normal value of the width of the optic nerve sheath diameter at this point. It's ranging between 0.51 up to 0.6 centimeter. There is a wide range in the literature. I'm going to come to cover this point. But what is found to be literally almost universal in most of the available literature, that once you see this optic nerve sheath diameter at this level, more than 0.6 centimeter, this indicates that the pressure around the brain in the subarachnoid space is higher than 20 millimeter of mercury, with very good sensitivity. Very, very good sensitivity means that you can rely on to rule out the presence of increased intracranial hypertension, i.e., if the width is less than 0.6 in most of the literature, you would say with confidence, around 90%, that there is no increased intracranial hypertension. While when it is positive, the specificity is lower than this in around 70%. One of the problems is identifying the cutoff point universally in all of the literature. You can find this. One of the studies showing 0.59 centimeter or 5.9 millimeter. It can be 0.5 centimeter. It can be up to 0.59 or up to 6.6 centimeter in some of the literature. The study we just published, me and my colleagues in our hospital, and it was accepted in the Intensive Care Journal of the European Society of Intensive Care Medicine as abstract in the meeting of 2017. We did a study on traumatic brain injury. We compared the optic nerve sheath diameter measured by ultrasound to the one measured by CT to other CT parameters of increased intracranial hypertension. And we took subset of patients who had an invasive measurement, and we compared both CT and ultrasound optic nerve sheath diameter to ICP invasive monitoring in 50 traumatic brain injured patients. We were combining this with a neurosurgeon and with radiologist. And what we found regarding the cutoff point, that when we increased the cutoff point to 0.6, the sensitivity was around 85%. When we reduced the cutoff point to 0.5, we found that the sensitivity increases, and this is biologic. If you say that any number above 0.55 centimeter is indicative of increased intracranial pressure, then the false negative of this study or test is going to be much lower. There are a lot of studies, and this a nice recent meta-analysis. Again, you're going to see variability in the cutoff points. And you're going to see also that almost universal, that the number of patients studied in every study was considered to be a little bit low, around 60 patients maximum. This might indicate that we need bigger studies, bigger multinational, multi-central observational, maybe randomized control trials. But look at here, for these two particular studies, the one used the cutoff for increased intracranial pressure 25 centimeter water or millimeter of mercury, around 22 millimeter of mercury, and this 20 millimeter of mercury with cutoff point for optic nerve sheath diameter was widely variable, 6.3 millimeter versus 4.8 millimeter or 0.48 centimeter versus 0.63 centimeter. The sensitivity in these two studies was not that different, i.e., if you go with this one, you better identify the cutoff point for yourself to be lower side better than the upper side. And what we suggest when we did some another statistical test, we found that 0.57 was associated with 100% sensitivity. On the same trial we did, we compared the CT to ultrasound. In high ICP, found high by the CT criteria, optic nerve sheath diameter, read by CT was equal to the one read by our ultrasound bedside in 100% of correlation. There was no any difference. And this meta-analysis, like the others, when they compared measuring the optic nerve sheath diameter using the CT and ultrasound to the invasive technology, what they found again, that there was no difference between CT and the ultrasound, bedside ultrasound. So why we have to move patients outside of ICU and risk them? Well, we can do the same. If you're looking to answer the same question, you can answer it by ultrasound like the CT for evidence of increased intracranial pressure like midline shift, effacement on ventricles, and the other criteria for increased intracranial hypertension by CT. Our study also, when it was comparing the invasive measurement to the ultrasound, was found very good and strong correlation to predict the high ICP was almost equal to putting a catheter inside the brain. There are a lot of meta-analysis, recent and old. And what we learned from those meta-analysis all, without going further in much details, that the optic nerve sheath diameter by ultrasound is a good sensitive, that the false negative results with to indicate high ICP are low, but not that much specific. So when you see high optic nerve sheath diameter, this is might not because of high ICP, but because of local issues on the optic nerve or any other etiologies. You have to be sure of your technique of measuring, and this is, of course, very, very important. Another meta-analysis, the same meta-analysis, indicated in their conclusion a very nice statement, which is if you have an indicated patients whom you are suspecting high ICP, ultrasound measuring the optic nerve sheath diameter can be a very nice alternative to use instead of invasive devices, particularly when you don't have a committed or a cooperative neurosurgeon to deal with. There are a lot of indications to measure the increased intracranial pressure in critically ill patients, starting from the traumatic brain injury, CVAs, hemorrhages, subarachnoids, many indications with a lot of evidence, though still repeating myself to say that the conclusion from small isolated studies cannot generalize strong recommendations. But what is very settled, as by our experience and by the literature, that you don't have to have a lot of experience to learn, to do, to interpret, and to start the journey of learning optic nerve sheath diameter, how to measure and how to apply in your critically ill patients. You just need to be observed. If you have some experience, 10 scans. If you don't have any experience, you need to observe and see. To be observed in around 25 normal scans and 10 abnormal ones. I just referred to you this meta-analysis which just published few months back, entailed almost all the literature. So far, up to the dates of 3 months back, including our study here, which was published as abstract in traumatic brain injury, what they found is, interestingly, that there was no difference between trained and non-trained operator if they learn how to do the optic nerve sheath diameter with the precautions that we mentioned, that you have to see the optic nerves clearly, and you see the borders clearly, you adjust your focus, you adjust your gain, and then you go ahead, don't worry. And what was found in the meta-analysis of more than 20 studies, that the most people using the optic nerve sheath diameter in clinical practice were found to be emergency physician, followed by critical care physicians. And least to do this was the radiologist, like many other things in critical care ultrasonography. I just highlight some of our experiences, cases that was found to be very helpful in detecting and intervening very acutely and urgently and saved life for. This is a patient with dialysis, came with disturbed level of consciousness, found to have intraventricular hemorrhage, and then and hydrocephalus, and the surgeon was not convinced. He said the blood looks old. Then we measured the optic nerve sheath diameter. He was not yet convinced. We told him she is deteriorating. When he saw her deteriorating, and this was very significantly high optic nerve sheath, 0.7, far away from the any cutoff, indicating very significantly that the ICP is high. With this clinical scenario, you have to intervene. And what he found intraoperatively, that the ICP, once he started to open and insert the catheter, was 29. Another patient, which we frequently started to see methanol intoxication. These two patients presented to us, and we reported them recently, 2 months back or 1 month back. We found that the optic nerve sheath diameter, if it's dilated in methanol, can predict ahead of time, before even the MRI, the optic neuritis because of methanol intoxication. What is the importance of this is optic neuritis is considered to be a herald of severe methanol toxicity even before you have the level. And you might rely on this to dialyze and give the antidote of methanol intoxication before even you have your level of methanol. Very interestingly, we started to see, and this is a very recent one, increasing or widening the scope of using the optic nerve sheath diameter in critically ill patients. Septic shock. What we see here, that with the septic encephalopathy, the optic nerve sheath diameter was found to be relatively bigger than those with no septic encephalopathy, due to brain edema, due to whatever it is. Cases of fulminant hepatitis and hepatic encephalopathy, grade 3, you might use it, because at the end of the day, why they got unconscious is the brain edema that makes them unconscious, whatever the underlying mechanism is. Among the reasons is the presence of maybe brain edema and increased intracranial hypertension. Optic nerve sheath diameter can help, and you can decide to give mannitol, and this patient was saved actually when we did the same. Ladies and gentlemen, respecting the limitations and respecting the growing evidence of the optic nerve sheath diameter, respecting that everything in ultrasound is operator dependent, respecting that yet we don't have big studies, but it deserve learning, deserve practicing, deserve that to include it in the future plans of research, teaching, educating our resident and junior staff, as well as the seniors, because it might make difference in the management plan, believe me. And I would conclude by the take-home messages, that if you miss high ICP, it can be catastrophic. It's sometimes very difficult to move your patients to have a CT or MRI. Difficult as well to get invasive measurement in coagulopathic or thrombocytopenic, or no available neurosurgeon to insert a catheter for you. Then you have alternative. The alternative should be in mind: ultrasound, bedside, non-invasive, repeatable, doable, teachable, learnable. And there is no difficulty at all in having this in your future plan. With this, I would refer you again to what Dr. Walid has kindly mentioned, and our colleague in GE kindly mentioned, that we're going to have advanced critical care echocardiography in continuity with the basic critical care echocardiography we just finished 2 months back. And we're going to have this one. If you are interested to join us, there are limited seats, and you can hopefully enjoy and learn. We learn together and we learn from each other. Thank you very much, Dr. Walid. Thank you very much for panelists. We can conclude now, open the questions, if you don't mind, Mr. Chairman, and then we conclude.
Okay, so a question here from Ahmad Zahir. How you often, or how should we measure the optic nerve sheath diameter? I'm sorry, okay. What is the value of optic nerve sheath diameter in axonal injury?
Axonal, what do you mean? Diffuse axonal?
Like diffuse axonal injury, yes.
Yeah, if there is high ICP, it will be helpful. Again, sensitivity is relatively high, sensitivity is relatively low.
Perfect. A couple of questions here for Dr. Walid Shebl. He promised he will answer them live. So we have like 10 minutes more to go through them. How will the brain ultrasound affect my clinical decision or patient management if I will need to CT the head anyway?
This is very important questions here. But really, if you see this holistic approach, and the patient came to you in ER, or you found the patient, and this has happened a lot, and the patient is very critical and cannot be shifted to the CT, and you find, I find the patient with brain death criteria, with reverberating wave, and you should give mannitol, and you should give Lasix and hyperventilation, and stabilize the patient as much as you can, and shift the patient to the CT, and call the neurosurgeon, because the patient should go from the CT to the neurosurgeon. So if your patient is stabilized, you can go to the CT, okay? And you can use the brain ultrasound in daily basis. If you are expert enough, you can use in daily basis, like you look for spasm, you look for the midline shift, if you are expert enough. But you need to document the CT if the patient is stable. But if your patient is unstable and you use a holistic approach and you collect a lot of data and you document it in the file and document it in the imaging, you take an action. You can take an action according to the clinical state of the patient and the finding of brain ultrasound. And once stabilized, shift it to the CT. This is the usual practice.
Perfect. So I think Prof. Daniel Lichtenstein has a question or comment. So please, if you open your mic.
Well, thank you. I will try to be short because you said there are several questions. Well, this lecture made me a bit not crying, crying because the optic nerve was described in my 1992 textbook, and I humbly think that I can revindicate its description in the critically ill. But, well, I forgot this because there are two problems that I see today. First, people use vascular probes, and I was afraid to see that it generated during the maybe first papers acoustic shadow instead of the optic nerve that the people measured. And they said, you must be at this level from the optic nerve because if you go down, it will enlarge. So they were saying that they measured an acoustic shadow. And my last point, for being short, although I have 1,000 of data that I was completely unable to publish just because it is impossible to publish, as you know. You are always rejected. I am occupied with the lung now. I could see that I do not have 100%. And the brain is maybe not a vital organ, as is the heart or the lung, but the brain is the more precious organ, philosophically. And not to have 100 is for me a hindrance. And I have bad experiences because of the sensitivity. That is, you can, to my opinion and to my experience, and you will tell me, you can find people, patients with non-enlarged optic nerve, and you see that there was a very severe brain damage requiring urgent surgery. So I don't regret too much to have been unable to publish regarding these last observations.
So that's a question to Dr. Ashraf Al Tayar, how you reflect on sensitivity and specificity of the optic nerve sheath.
Sensitivity mostly.
Yeah, I totally agree with you, Prof. As I mentioned, it is carrying a lot of some limitation, let me say it, in a political way, some limitations. And maybe it is a little bit more than the rest of the examinations, it's more operator dependent. You have to see the optic nerve and to be sure that this is not a post-hyperechoic shadowing of anything. And then you have to have the criteria of that this is what match anatomically the optic nerve sheath, where to measure it, what cutoff point you have to go with, and understanding that the limitations of the cutoff point is very important. But again, if you put it as one of the puzzles inside the context of many other puzzles to come up at the end of the day with diagnosis and new plan management, probably, yeah. For example, the cases I present, would I go with any hepatic patient and do optic nerve sheath diameter while he is conscious? And if I find that this optic nerve was dilated in this hepatic patient, would I give mannitol and bother with the high ICP in a conscious patient? No. The other one, the one presented with dialysis, hemorrhages, and was found to have hydrocephalus, level of consciousness was deteriorating. If you have evidence non-invasively and was unstable to move to anywhere except to OR. So what I want to say is we should not deselect any study from the context. And this applies to everything in life, I guess, Professor Daniel Einstein.
I believe like Marshall in CT, Marshall use a score with effacement of the sulci, with disappearance of quadrigerm cister, with collapse of the ventricle. We need to use the brain ultrasound as a holistic approach. We need not to look for the optic nerve sheath diameter, but to look for hyperechoic hemorrhage, to look for the midline shift, to look for the PI. And I'm sure if we use these 4 parameters as a score and to compare the gold standard, which is the invasive intracranial pressure monitoring, we'll get a very high sensitivity result. I use that in daily basis for years, and I have a lot of cases, and I will be happy to share with Professor Daniel this holistic approach. We confirm by CT, but even if we use the intracranial monitoring invasive, will increase the value of the brain ultrasound, especially with the harmonic mode. Harmonic mode improved the image a lot for brain ultrasound, and this is very important. And unfortunately, the company don't know about that. They leave the software of transcranial Doppler without harmonic. But when I tried the phase array probe with the harmonic mode of the cardiology, it gives a very good pictures. Okay? Yani, as regard optic nerve sheath diameter, I use the optic nerve sheath diameter and I used to fire the pulse, the color wave and the pulsed wave Doppler for the central retinal artery to measure the resistivity index of the central retinal artery. If there is a tension in the subarachnoid space in the CSF around the central retinal artery, it will impede the flow in the central retinal artery and will increase the RI. This is a point with the dilatation of the optic nerve. So we need to collect all this when I talk about, I give a case report in the EC emergency medicine, very full case with all the images. But this is what I believe in brain ultrasound. We shouldn't use it piece by piece. And Professor Ruba did a study, recent study, using the velocity of the straight sinus, big velocity of the straight sinus, with the optic nerve sheath diameter, and the area of the curve improved compared with the optic nerve sheath parameter alone and the big velocity of the straight sinus alone. So using these multiple factors and comparing with the gold standard will solve the problem and will help a lot the intensivist, because really I have a European certification with the EDIC, no brain ultrasound in the forum of the EDIC, and even the American Society of Critical Care ECHO didn't put the brain ultrasound in the curriculum. Really,
perfect. So we'll give the mic, please, Dr. Walid, to Prof. Daniel, just to get the last comment.
Well, I summarize your talk. You say that one piece is not sufficient, like everywhere in medicine, but I just think that we should emphasize to the young generations that up to now, the optic nerve alone should not generate such enthusiasm in the literature. And I wonder how the literature that is peer-reviewed medicine is so enthusiastic with something that is working not so bad, but not perfectly. That's all what I wanted to say.
Perfect. So I think we will conclude here we'll end the session. We have 1 minute. Dr. Ashraf, if you want to say anything before we conclude.